So welcome, everybody, and thanks for staying for one of the last sessions of the day. I wanted to make this a little bit more interactive than the other sessions because there's a wide range of discussion topics that are possible. We have some that are very, very involved little babies all the way up to less involved adults. So I think it should kind of flow as to what you want to see. I have pictures of different exercise options in terms of sitting and lying down and standing, and then I have pictures of equipment and AFOs and all that kind of stuff. So it runs the whole gamut. So I think what I could do is start with like just a brief overview of what you should be looking for, and then we'll go to some questions. Does that seem okay? All right, okay. So anyway, my name is Meena Jain. I'm one of the physical therapists at NIH. I've been involved with all the NAC and the RICAL trial, and I'm part of the RYR1 natural history trial that Irene is she's recruiting for. I am one of the PTs that will do the motor assessments. So we're the ones that are pushing you to do what you need to do and all that. So, okay. And I've been at NIH for many years. Let me just forward. Oh no, I got to forward from here. Okay. So I've been at NIH for over 32 years. So a lot of my, and I am a member of the Scientific Advisory Board, so those are my disclosures. So this is from the last conference, and I wanted to just throw it in. It's kind of cute if you recognize these kids. Oh, what is it? Why is there no volume? Oh. I don't know what happened. There's no volume. Thank you. Mm-hmm. See, this is the only volume that I need.
Should be correct.
Try it again. Oh, maybe. Is that what it was?
No, that one's up. We're at max, so.
Well. There we go. Maybe that's it.
I'm sure it's not liking it.
Try that. Oh, it's already went.
Yeah.
Well, it was a cute TikTok that I had the kids do last time, so. My money don't jiggle, jiggle, it fold. So anyway, so the point of it was that we could do something fun. So anyway, the objectives of this talk is to discuss comprehensive symptom management, which is really important. To learn to develop an tailored exercise prescription, reviewing bracing and equipment options, and then some proactive planning for future needs. And so in terms of symptom management, I'm just going to go through all these. There's a lot in terms of contracture management for some people who have contractures, tightness, and difficulty with range of motion. Pain and fatigue has been an issue. We've had a couple of people come in recently for the RYR1, the natural history protocol, so I've asked specifically, what do you want me to talk about? And pain management was something that was brought up. Maximizing functional independence, that is the most critical goal of any physical therapist, is to get you to be independent as possible. Exercise prescription, as we've talked about, and as we've talked a lot in this conference about malignant hypothermia and rhabdomyolysis, I think we've heard a lot about it, but I'm just going to hone it in again one more time in terms of being careful about developing your exercise program. Equipment recommendations, and then to highlight again that the RYR1 clinical guidelines, there's only literally 2 pages of information on physical activity and physical therapy. And this was developed in 2020, so it's 5 years old. And this is kind of what it shows, is that it's a consensus statement. It was developed in 2016, and just kind of do exercise 30 minutes, 3 to 5 times a week. So it's very nonspecific. And the reason why it's very nonspecific, it's because every exercise program should be tailored to the therapist, by the therapist for the patient. So if you were to come up and, like, in a group of people, someone's like, I need exercises to do this. Well, I wouldn't be able to give you an exercise for this because I really need to know overall what's going on with you to be able to tailor the exercise program to you, and that is really what's important, to maximize your independence. And that's what makes it difficult to do research related to exercise prescription for people, because everybody's going to be different, and you've heard us talk about this. So, but anyway, that's where we are. And then the things that we've taught in the guidelines is to avoid high-impact sports, make sure that you do low-impact sports, slowly build it up. Don't just jump right in. Make sure you're careful about don't do it in extreme temperatures, not too hot, not too cold. Kind of do it like an indoor if you can. Some people, like they did swimming. I know Kurt, who's talked to here, he swims for exercise, but he can tell if the temperature of the pool is a little bit higher, and then that throws him off. So those are the things that you have to be aware of. And if you can't get to exercise, if you get too tired quickly, then you know you've done too much. I think we talked about it in the earlier session. It's the recovery the next day that's really important. Again, I'm going to keep highlighting that. Again, that's a question that a lot of families ask me. How much should I exercise? I don't know. I can't tell you now. I can tell you tomorrow if whatever you did today is too much, because it depends on how your recovery goes. Okay? And then again, exercise is different. It has to be tailored to you. You hear that over and over again. And then lastly, but most importantly, I don't think it's on there, but if you have a therapist or somebody who tells you to push through the pain, yeah, find a new therapist, because that's not helpful. You do not need to push through the pain. And as a profession, we are moving away from the no pain, no gain. If you go to a trainer, if you go to the gym, they may do that, but physical therapists do not push through the pain and operate on that assumption. So, okay. So these are some of the questions that are posed by a lot of patients and families. Most important is, why should I exercise? And I brought it up in the other one. Why should you exercise? Because you need to be independent to walk to go to the bathroom. Just those are the simple things. The minute you need someone to help you walk to the bathroom, that takes away your independence. And that's the most important function that you can do that is yours and nobody else to help you. So that's kind of what I tell families. But other than that, you need to improve your fitness level. You can do something fun. There's always an activity that you can do that's fun. It's great for your mental health. So exercise doesn't need to be, I got to carve 30 minutes out of my day to do this. I need to exercise is just get up and move. So it's not, we should get away from saying exercise and just say physical activity. So I was talking to another colleague of ours over here, and we've been inside here all day long. So going just to the airport on that walkway, just walking to the walkway is activity. Go ahead and stand on that walkway, but at least it's good for your mental health because you're away from here. You give yourself a little bit of a break, a mental break, a physical break. So just doing some activity all the time. And then we can try to maintain whatever you have in terms of muscle loss, or we can slow it down. Hopefully we can slow it down so that you can at least delay the progression, okay? So what are the activities that I need to do? A hallmark of 3, stretching, strengthening, and aerobics. So stretching exercise, like we all say, stretching, you know, we have to hamstring stretch, heel core stretch. Those are all stretches that your therapist can give to you, but just moving for general mobility. So even just doing this for me is a combination of stretching and aerobic activity, just this right here. So anybody can do that. Even if you're limited in your mobility, you can do a little bit of activity. Strengthening could be as simple as, so one of the things that I make my family members do, like I've had family members do, is have your child or adult help you put the cans of whatever into the cabinet or put the dishes away, because that's a little bit of strengthening, because you got to reach, you got to put the dish, you got to put the plate, you got to put the can of beans, you got to put those away. So that's strengthening. So even just that little bit of activity is helpful. So the idea is to do little breaks through the day for activity. And then aerobics is something more, aerobic you have to do a sustained period for heart and health, for heart and lung health, and the recommendation is 30 minutes, 30 to 150 minutes through the week. So whether you do 30 minutes, 10 minutes, or 30 minutes, 30 minutes, 30 minutes, but the idea is to do it sustained at a consistent level of exercise. So just getting up to, you're sitting down, you want to get up to get a glass of water and sit down, getting up to put away a dish and sit down, that doesn't count as the aerobics. You need to do a sustained. So just walking continuously would be considered a sustained activity. So that's kind of the aerobic part. So if you are limited in your mobility, then you could try to do, they have tabletop bicycles, you can get a tabletop bicycle, or just, one of the things that I have some of our little kids do is to play volleyball repeatedly with a balloon. So just hitting a balloon repeatedly if you can. That is a sustained activity, that's aerobic. So that's kind of what you need to look for. How much should I do? How often should I exercise? And how do I know if it's safe? So that's when it's important to meet with a physical therapist, and a physical therapist can design a program for you that's safe, and will provide you with the right prescription of exercise in terms of how much and how often. Generally, we do 2 to 3 times a week. For all these, you can, if you are very ambitious and motivated, you can do every day and then break it up between stretching one day, strengthening one day, aerobic one day. But the idea is just to do something at least 2 to 3 times a week. Okay? Any questions so far? This is all you've heard this, right? So, okay. So the recommended, again, I want to go back specifically for RYR1, limited, low-impact supervised exercise. It could be biking, walking, swimming, for if you don't have a mobility challenge. And then you want to listen to your body. If you feel excessive tiredness or soreness, then to step back. And if you have a little one who cannot explain to you that they're tired, what you do is you have to be aware of their behavior. And if you notice that they're doing more timeout activities, they're sitting down to, rather than playing, they're reading a book or playing a puzzle. Those are the things that those are the clues that you need to look for. If they're very, very little, like I see the little ones in the stroller, if they're not moving at all, you have to look at how they're breathing. If they're like labored breathing or they're just working harder, those are all signs that they've worked too much. So those are things that you have to be mindful of. And then the two that we've talked about a lot, you've heard, is the malignant hypothermia and then the rhabdomyolysis. So those are the two things that you have to be careful if you have those, that variant, and especially making sure of extreme temperatures and not working yourself during those 2 extreme temperatures. Okay? Any questions? All right. So now we'll go to so I'm just going to, again, we talked about stretching. Okay, so the most common area that needs stretching is usually the knees and the ankles, because you get tight heel cords and then tight hamstrings. And then if you're in a wheelchair or you're sitting in a mobility device, you end up getting, those are the muscles that get tight, and then the hips also get tight if you sit too much. So those are the areas that you need to really focus on stretching. Strengthening will be isometric, so no eccentric contractions. We talked about concentric contractions or isometric. Isometric is just like holding, so concentric, I don't know if Dr. Razi DeBraza talked about it. So concentric is if you're lifting, you're going against gravity. So I'm holding my phone and pulling it up. That's concentric. And isometric is I'm just holding. So like I hold and I'm making a muscle. Like so when we do a muscle, that's what we're doing. We're doing an isometric. And then eccentric is when you're slowly lowering. You're lowering this like my phone. So I'm eccentrically contracting my triceps. That's a lot of. But if you're doing, then your next question is if I'm doing this, I'm going to do this, right? But there's a way for the therapist to teach you how not to do this, not to do the eccentric. So that's what you need to be, that's why you need to work with the physical therapist, so they can teach you how not to do an eccentric contraction. So there are ways. So those are things that you need to worry about, but those are the things that you need to meet with a physical therapist to kind of go over it. So now, working with a physical, like a trainer, I wouldn't recommend it. I would probably work with the physical therapist, and then you can go to a trainer to work with a trainer afterwards, but start with the PT, okay? And in terms of weights, I've heard some people ask, what weight should I use? I'm not a big believer in free weights. I like resistance bands. And the reason why I like resistance band is that there's a little bit more give. If you have a 30-pound weight or a 20-pound weight, it's not changing whether you are tired or not. Whereas if you have a resistance band, if you feel a little bit tired, you can step in closer, pull away, and then you're going to be working harder or easier if you have a band. And there are ways to make resistance bands difficult. It's not the range of resistance band, there's 5 levels, goes from yellow to black, and the therapist can kind of work with you on that, and you can get them easily on Amazon, but do not get them until you talk to a therapist before you go out and try it out yourself. And then the other one is that I'm not included on there is body weight resistance. So sit to stand, doing push-ups, those are all body weight resistance exercises, if you're able to do that. If you're not able to do that, if you can't do a push-up, you can do a wall push-up. You're still working on strengthening, but you're not having to do it against the floor. Even sitting to stand is going to be hard, so then you start with a higher, like if you have difficulty getting up from this height chair, you put a pillow underneath you, practice that, and then slowly take away that pillow and then go from a regular height chair, and then you can work on that. So there are ways to do body weight resistance, okay? And then aerobics, I've talked about swimming, walking, wheelchair mobility. Okay. Let's see, sorry. So contraction management is very important. This is gonna go back to the young kids. Standing and walking is very important. So it's important to get kids in a stander as soon as possible, up to like, if you can get them in before 2 years of age, when typically developing children are already walking around, that's really important, not just for their bone development, but also for bowel and bladder health, lung health, social development, all of that. So there are multiple of standards available on the market. Just have to work with your therapist to see which one works best for your child. They have ones where you lie down and you stand up. You have one that you lie on your stomach and stand up. Ones that you just sit in it and then it stands you up. So there's multiple ways to get a child upright and standing. And then if you have a stander, chances are you'll need braces, AFOs, to make sure that they can stand in the stander, because you don't want the kids to have to work really hard. So you have to work with a therapist and a physiatrist or a neurologist to write the prescription for the braces. And there's tons of braces. Yes?
What might you recommend for contractures in the meantime, like while we're waiting the 6 months to get an insurance?
So what contracture do you have?
Knee and hip flexor contractures.
Okay.
We do knee immobilizers at night, and we have an AFOs for people already.
So neobulizer at night is fine, is good. I'm not a big fan of night braces, and the reason why I'm not a big fan of it is because a lot of times the kids don't like it, and then they get cranky and they don't sleep well. And I'm sorry? Okay, well then he's fine. Then he's fine. I always ask the parents because if the child is not sleeping, then they're waking up the parents, and the parents are not sleeping. But if he's fine with it, then yes. And then. Yeah. And then also, and for the hip flexion contractures, then laying on his stomach, and then you'd have to do like a physical stretch. yeah. So, and I think I have some pictures later on, but we could go, yeah. So, yeah. And then for ankle contractures, if you had it, if you're waiting for an AFO, I recommend like high top boots for kids. Yep, yeah. Okay. Uh-huh. All right, so so there's been some studies about surgeries in terms of doing surgical repairs. It's pretty common for hip in terms of more like hip flexor tightness or adductor tightness to do the surgeries, or hamstring tightness. Heel cord lengthenings are very common. Very little is known, or actually let me say, the outcomes are mixed in any type of upper extremity contracture management surgery. I know Dr. Bonham, and he talks about one patient who had terrible, terrible elbow flexion contractures, and they went and fixed it, and then this child was stuck here. So you are at least functional here. You can eat, you can comb your hair, you can do this, but if you're stuck out here, you can't do anything. So that's something that you would need to talk to. And sometimes if you go to only to an orthopedist and not talk to your physiatrist or neurologist about it, it can be a little bit more detrimental because they are thinking with their orthopedist hat and not combining in terms of neuromuscular, so that's important. Okay. Okay, and then stretching in a standing frame. Everybody asks me, how much should I stretch? Will it help? Whatever. Like, do 30 minutes in the stander, 60 minutes in the stander. There's very little. The only evidence that I have seen that's out there that is helpful is in children with cerebral palsy in a stander for 60 minutes a day, 5 days a week. Well, I don't know, so we don't have enough research to be able to say that in children with RYR1, it's important to be in a stander for an hour or 30 minutes or whatever. Mostly we go on whatever your child can tolerate, and you want to do at least a minimum of 30 minutes if they can tolerate it. But if they can tolerate longer, fine. But if they can't, then there's no point fighting it, because then they're going to be miserable, you're going to be miserable, and you're not going to be effective at all. So in terms of how long to hold your stretch, there's the next picture shows you pictures of stretching. We say 30 seconds you're supposed to stretch, but can you have the stamina to hold it for 30 seconds? And is the kid gonna tolerate it? So do it as much as you can, 10 seconds at the most. My response to any family is that do not beat yourself up if you notice that the child is getting a contracture. There'll be a time when you cannot help it, and just know that it's okay. Like I have had families come in and say, oh, we let it go. No, you tried, but it's not possible all the time to be on top of it, because you're focusing on one thing. You're focusing on their lung health, and then you let go of this. You have only so many hours of the day, so just know that it's okay, that there are times to let go, and that's when you need a good therapist to say, this is the most important exercise that you need to do. And they should only be able to, they should give you one or two at the most to say that these are the two most important things to do. And that's what you have to take away, okay? So here are just some pictures of stretching, ankle, hamstring, all those. And these are, the one over here is for the hip flexors. I don't know. Whew. I don't know if it's working. This one. And these are some other photos. This is a way to do for adults, but I can tell you that I don't have the balance to do that myself, the one on the far. He's laying over a table and lifting his leg up. I don't have the balance to do that, so, okay. Okay, strengthening we already talked about, I'm just gonna push through. So these are some general ways to do standing exercises who don't need support, and they can do it in standing. And standing could be just as lift as bring your leg out to the side, bringing it behind you, any kind of hip girdle muscles, and then some abdominal strengthening, trunks, bringing it above your head. These are all just very simple, basic exercises that we can incorporate for someone who is not standing, or who is standing and does not need the balance. And then these are some lying down, seated exercises, resistance. So the point of showing all this is that there are ways to modify any exercise, any muscle strength for you based on your needs, okay? These are functional body weight, so sit to stand, going up and down stairs, even just to step up and down, hold on to the railing, step up and down real quickly. And then water-based. I recommend water-based services, water-based therapy, water-based play, anything in the water, as much as possible, as much as practical, and if you have access to it. There used to be a time, I don't know if it's true anymore, like this hotel has a pool. Sometimes if you don't have a YMCA or pool near you, a lot of the hotels will let you use their pool. There used to be, again, I don't know now with everything. They used to allow you to use their pool as long as you sign a waiver saying that you're not gonna hold them liable. The only problem with hotel-based pools is sometimes they don't have a lift to go inside the water, so you kind of have to look at that. There's another, Airbnb for swim called Swimly, SWIMLY. So people rent out their pool, like if you have a pool in your backyard, then you can borrow it, whatever. But again, that's costly. They may not have a lift, but there are other ways to do that. And if you have a young enough child, just your bathtub, but of course want to make sure that you're always there for safety. So. The other thing that I have included in there, but these are just ways to like strengthen in the pool, but in terms of, I don't put pictures of any kind of flotation device because there's many on the market and I'm not supporting one or the other, but you want to make sure you get the right safety devices for yourself or your child. So they have those armbands, not a big fan of those. They have swimsuits that have little pockets that you put in the floaty things. So, and the reason why I don't like the armbands is because the arms are stuck here, and then you can't do anything. But if you have a little floaty thing, and it's like a life jacket kind of thing, then at least the kids could use their arms and the legs. There's one that has been used a lot that I've seen is like a little neck brace around the neck, and the kids, they are hanging in the water. I never used to recommend it because I always think, oh my gosh, they're gonna choke on it and they're gonna slip through and it's so unsafe. She was a 19-year-old young lady, not with RYR1, but with quadriplegia, cerebral palsy. And that mom said that, Mina, why are you not recommending these? Because my daughter is liberated in the pool. She said she puts it in there and then she can move her arms around, legs around. She can never do it outside of water. So I've changed now. So now, like, if you find one that works, then go ahead and use it. So, okay. All right. And last but not least, so water, aerobics, any way you want to do it. Adaptive sports, dancing, playing. Adaptive bicycle is big. Those are some things. So that's the part of the exercise. Now we're going to talk about bracing and equipment. Any questions so far? No? Okay. Okay. So here are some equipment on the market. I don't know all of them that's available, but you can have a variety of ankle-foot orthoses. You can have a variety of hand splints, body jackets, knee braces, hip, ankle, knee. Those are pelvic. They call RGOs, where reciprocating gait. Well, as they wear the hip, one leg goes in front of the other. There are many on the market. It's really, really hard to keep up on them. And then there's different ones that come up all the time, different manufacturers, different. So the reason for this is to say that there's a lot of things out there to help your child or yourself, to help you support what you're doing to maintain that goal of staying upright and walking for as long as possible, okay? So the thing is that you have to talk to your therapist, your physiatrist, Physiatrist, does everybody know what a physiatrist is? Physiatrist is a physical medicine and rehabilitation specialist. So you have a neurologist, you have your pediatrician, and there's a physiatrist, and they deal with equipment and all that. So some places don't have them. So if you are working with one, that's good because they can write the prescriptions and the letter of justification for equipment. But if not, then your therapist and neurologist can help you with that. So it's really important to work with somebody to get these devices, because there are some off-the-shelf ones. I know Amazon sells them, but they may not be appropriate for you. So that's why it's really important to know what's available through your therapist. And sometimes your therapist doesn't even know about it, so you can show a picture and say, hey, what do you think about this? And then kind of go from there, okay? And now we're going to talk about seating options. I only have 3 pictures, but there's over 100 of them all over the place. So again, the purpose of a seating option is to make sure that the child is in a good, comfortable position that's going to support them. And if they need more support, then you would have the right harnesses or lateral side supports or hip supports. There's many, many out there. Again, you need to work with a professional who can help you with that. Many major medical centers that have a lot of kids will have a seating clinic, and then usually that brings with the vendor, the OT, the PT, the physiatrist all together, and they all kind of talk about it. So that's where you can get some equipment. So to tell you, this is my favorite. It's called a corner chair, the one in the blue, because then you can have the child on the floor. This one. It looks like a corner, so it's somebody doesn't have a lot of trunk support, you put them there. They have to have a little bit of trunk support, but then that's something that they can sit on the floor and not have to, they won't fall over, so, okay. And then we have equipment, standing frames. So this is, I'm telling you. Oh, yeah, here it's working now. I was just pointing it in the wrong direction. So this is a mobile standing frame. So it allows, it's not like a wheelchair, but it lets you move a little bit. So this is the mobile standing frame. This is another, I think it's called a tadpole. I don't know. I don't know the names of these devices because there's so many that come, but these are different. This is the one that you can lay down. It's in the front. So this is front, and then there's the tray in front of the child, so they're leaning kind of into it. And this is also, but this can go both ways. They can lay on it with it in front, or they can do it with it behind. So there's multiple ways to do it. So it just depends on what your child needs. Okay. And then we have a variety of mobility devices. You have walkers. This is more supportive. You have just a plain old walker. You have a motorized wheelchair. Don't call it an electric wheelchair. Call it motorized. Because whenever I hear electric, I think of the other electric chair. I know, I'm sorry. Sorry. This is a scooter, and this is called a Go Baby Go. So Go Baby Go was a program started by the University of Delaware where they would take regular, those cars that you get at Walmart, Target, and then they adapt it for children who need it, and to allow early mobility, because that is really, really important to get kids mobile as soon as possible for motor development, for language development, social development, just overall. So they started this program, and so you can Google Go Baby Go and try to see if there's like a local university in your area has a program where they will build one for your child, and it's usually a charitable and it's free. So, but it's something that I think it's very, very helpful for kids, early mobility. Okay. All right. Next, this is the last 3 slides in terms of, or 3 items that so one thing is that a lot of families come to me and say, what about a SPEO suit? I don't know if anybody knows of it, if you have it. It's like a very compressive suit that kids wear, and the idea is to give them a support, tactile support to be able to sit up properly. okay? So for the women out there who use this, if you think of Spanx, when you wear the Spanx, you're sucking it in, you're sitting up nice and tall, but the minute you take the Spanx off, you're just like black to where you were before. So these are okay to use temporarily, but once you take it off, it doesn't work anymore. And they're hard to put on, and they're expensive because most insurance companies don't pay for it, and it's out of pocket. There is no research to show that it helps, but there is no research to show that it hurts. There are some kids that do well in it, and they're fine with it, they're okay wearing it. Go ahead, there's no need to not use it. But then if you're considering this, if you've limited resources, this SPEO suit that could be $600, $700 versus taking them to the pool and doing water-based, I would always say do the water-based. But the SPEO suit is, my feeling is it can help. It may not hurt, it may not help. It's a lot of effort to put them on. So that's what I feel. Rather than the SPEO suit, I've had some success, not with RYR1, but with other populations, using kinesio tape. They're doing it on the knee, but I've done it on the back. I've done kinesio taping, and you can do it for little ones on the back to help with the little bit sitting up straighter. So ask your therapist about that. There's lots of training that they can get to learn about kinesio taping. The last thing up there, I just talked to Dr. Mayer about. This is called an inspiratory trainer. It's different from your spirometry. It's called an inspiratory muscle trainer, and what it does is that you have to set it at a certain level for your particular self, and it works on your inspiratory muscles. I talked to Dr. Mayer about it, and he has not had experience with it, but he said it doesn't hurt. There's no research to show that it hurts. Doesn't have any research to say that it helps, but it's kind of an innocuous way to work on some inspiratory straining. One of the therapists that I work with at NIH, he works with adults and mostly acute care ICU patients. He's been using it with all of his ICU patients, and he has said that he's got a lot of anecdotal evidence that it's helped in that population. He's had some adults that have used it, and it's increased their ability to walk the 6-minute walk, like 50 meters, 70 meters more after using the inspiratory trainer. And it is like an exercise program, so you have to do it on a regular basis, a couple of times a week. It's like a modality. So for your older kids and for yourself, you can look into it, but talk to your therapist first because it has to be set. You can't just go on Amazon and buy it and then start using it. But this is something that I would like for us to start thinking about in this population because it could be helpful. So it could be something that I can talk to Dr. Mayer, and then in terms of we would see if it's something that could be like a research study for the future. But for now, this is just a anecdotal. We think it might help. We know it won't hurt, so, okay. And I think, okay, so very basically, you want to make sure that avoid eccentric, avoid strenuous, and work on energy conservation. Okay. All right. I think that's all. So basically for the future, I don't really have many slides. I thought I did, but I don't, I guess, is to continue with upright mobility, stay upright and walking as long as possible. That is what our goal is. Even if it's walking once a day from one end of the hallway in your house to the other end of the hallway, continue to do that. And as I said, back again, if you can walk from your bedroom to the bathroom, that is the most important hallway part to go to. So you got to kind of work on that. And then working on managing how are you going to work as you get older, how are you going to manage at school, how are you going to manage at work. Those are things that you need to start planning ahead and thinking about, asking your therapist. I think there's been sessions about 504 and IEP plans. So as your child gets older, you need to kind of incorporate some of those goals into the IEP plans. And then, of course, the most important thing, and I think I said it in the other session, the goal of physical therapy is to get you and your child independent with your activity level so that you don't need us anymore, because there's more to life than sitting in a clinic and doing therapy. And I applaud families that decide to take a break and say, we need a break as a family from therapy. That is great. I would rather you take a break and do something fun than come into PT, because it's really, really important for the whole family, because it affects the whole family, not just yourself or the child. So, all right, I think this is the last. Yeah, so it's a team effort. You need to have your neurologist, I put in physiatrist, PT, and then yourself. And then in terms of finding a PT, so I brought this up, so you can go to the apta.org, and there's a website that says Find a PT. You want to look for a therapist who is neurologically certified specialist. They've got an NCS after the name, or PCS, who is a pediatric specialty designation. Those are therapists who have done a little bit more advanced in terms of neurology and pediatrics. That's not to say that your local therapist at your home facility who is a pediatric therapist, they may not have the designation, but they've had enough years of experience. But if you're just Googling and looking for a therapist, those are the things that you want to look for. And then the other thing is to ask about all these questions. Do you have experience working with people with RYR1? Do you know the common symptoms? Most importantly is, what resource do you have to learn about this condition? So I can bet you, I've had more experience with RYR1 because I work in a center where all the people come. But then there might be a therapist out there like, oh, I've never heard this, and I'll be honest with you, when I graduated from PT school, we just learned about muscular dystrophy. And as I got older and started practicing longer and longer, now we have the gene that identified muscular dystrophy, and now we're doing gene therapy. Well, I didn't know anything about that. I didn't know there was a gene, so there's a lot of things that we learned as PTs how to deal with, but as science has evolved, we are learning now. So as long as they have the resources to figure out more information, that's what you need to. You need to have someone who's a partner with you on that. So, okay. I think I already did this, so I'm just gonna, okay. That wraps up that part that I wanted to talk about, but I would like to open it up for questions for you guys. These are the things that we're doing at NIH. I can bring that up if you want, otherwise, but I know Irene's talked about it. But this is now your time, if you want me to talk, if you had specific questions, or want me to talk about the outcomes. Yes?
So our son gets his PT and OT services through the school system.
Yep.
And then outside of school, we do like dance or swimming. But do you think it's beneficial to also find a physical therapist outside of the school who, like, the physical therapists don't know what RYR1 is?
Correct.
They actually have said they just treat him like muscular dystrophy.
Correct.
But is it helpful to find PT outside of that setting and have that extra?
So the goal of physical therapy in the school system is for your child to be successful academically. So if your child is not able to go to their class, or they're not doing gym, or whatever, then that was why they would get physical therapy. They're not going to work on specific, my kid has a tight heel cord, they're not going to work on that, unless it impacts his ability to walk to class, yeah. And then comes the private therapy. The private therapy, they will require like specific goals. You can't just say, my kid has RYR1, I need therapy. They will work on specific goals. And I think in those instances, you can come up with goals like, this is what I want my child to be able to do. Let's do this therapy to be able to get to that. And then learn what needs to be done, and then continue on with it. There's always, that's always a good tactic. The other thing is that there's like what they do, intensive PT. Like, so some therapists will see once a week for months and months and months, or you can do an intensive 3 times a week, 3 to 4 times a week for 3 weeks, and then really, really get in, and then try to follow up with the services at home so you're not going there. That's another way to do it. So I didn't answer your question. So your question is, my question is, like, what are your goals? Like, if your goals are being met with school PT and what he's doing recreationally, and he's doing fine with those goals, then I would say, why add something else? Do something else more fun. But if there's something like he's not keeping up with his classmates, he's really, really tired, I need a therapist to come and give me some ideas of what we need to do to make sure to maximize what he can do, then yes, I would say get private PT. I will also tell you this, depending on the insurance company, sorry about that, depending on the insurance company, they do pit against each other. They'll say, oh, you're getting it at school, so we don't need to give it to you. And then the school will sometimes say, oh, you're getting it privately, you don't need to get it. So you need to be an advocate. And the words I used, to be successful in an academic environment is what you need for school therapy, and then privately is to be able to meet the other goals. So, okay, sorry.
Just to follow up on your question, we're lucky we're close to CHOP in Philadelphia, but we had like a bunch of years of PT before we went to kindergarten, et cetera, and that was important because some of the school-based PTs or OTs just don't understand the disease.
Right.
And we're setting them up to like hurt themselves. They're and we were lucky enough, again, big school district, we get a lot of support from the school district, so but some of them just don't understand. They came over in the summer and they wanted to do almost like a plank thing where he's gonna smash his face, and he doesn't have that, strength. So it was good to have like the PT through CHOP and neuromuscular and all that to kind of come up with that. These are the things that we know should help him hopefully get a little bit of strength so that you can pass that on to the school in the event that you get additional, time in school. So I don't know, each school may be different, each PT is different, but that's just our experience was getting some of those tips from
The
PT
PT.
that knows the disease can help, And again, they're not being malicious, it's just, they were giving some exercises
Yeah.
and we're like, he's gonna hurt himself, so.
Yes, sorry.
So I work with physical therapists, also at CHOP, with amazing pedigrees, et cetera, but I'm really struggling to find therapists who are comfortable with trachs. Do you have any resources for that I can show them, or is there a way to kind of search for physical therapists who are comfortable with trachs? I just find that to be blunt, a very lacking part.
I don't have an answer for that, but I will start looking into that. I don't think there's any, the APTA may have resources for trachs. I just have to find it. So you can get my email and send me a reminder, and I'll look into it. But no, I don't have an answer for you. So, but I will find an answer for you. Yeah.
So we started looking into those Trexo robotic gait trainers
Yeah.
for our son, and then Trexo got back to us and said we no longer serve the U.S. We're only in Canada. So do you know of any is there any resource, different company, different brand that? 'Cause I feel like from watching the study, or study might be a strong term.
Yeah.
But from watching the experiences of that, that's great movement that we're not initiating, Andy, my son, is not initiating on his own. So is there anything like that?
So no, I don't think there's anything out there. The closest that you're going to get here is the body weight supported devices, and there's a device called Zero G and Lightgate. Those are two names. Those are brand names. So Zero G is going to be really hard to get. It's a ceiling-based equipment, and the kids are in a harness and they walk, and so those are. They're very expensive to install, and I know that because we just went through the installation at NIH. But the Lightgate is another device that can be helpful, and that's a portable device. And actually, there's a third one, and I am blanking on the name. It was used in an SMA trial at Nationwide Children's, and it's something that it's pretty cheap in terms of, it's something that, it's a 10 by 10 frame that you can put up in your house, and it's got tracks, and the kids can wear like a harness, and they can walk and crawl, and yeah. So get my email, and I will find it because I am blanking on the name right now. If I can find the email, I'll get it to you. So this company is based out of Delaware, and I know they use it for the SMA trial through Nationwide Children's. So yeah.
I'll look to that, and I think I know the answer, but you know more. You were showing the different braces.
Yeah.
So like the hip and knee, like the ones
Yeah.
that do all that. Do you still have to have your own weight-bearing ability to be able to use those, or are those, okay?
Yeah, they're just supportive. You can't, because putting somebody in there, they still have to use their muscle if they have no muscle, and you don't want to put them in too quickly. And honestly, they're heavy too, so, yeah. Yeah, yeah. Yes.
Do you have any suggestions for public school staff training?
Where do you live?
New Jersey.
Okay, well, so New Jersey is a little bit more relaxed, but no, I don't have any, so the American Physical Therapy Association will have some white papers in terms of, but you may not have access to it. I know they specifically have one in terms of muscular dystrophy, but not specifically to RYR1. Maybe you're a therapist at home, they can get access to it, if you have a therapist at home, so.
I'm having the same thing with,
What school?
the school staff has hurt my son on numerous occasions because they don't understand this condition enough.
Right.
I would love to, take our son to as much therapy as possible, but you have to have a life too.
Yep.
It's not physically, and by law, they can help, with school. I would love for him to get the therapy in the school, but they need the right training. Some of them need to be accountable with the right training, and the hardest thing is, they're like, we want to do the training. What training? Because RYR1 is so,
Right.
it's not, it's like a dystrophy, but not a dystrophy. And
Right.
it's like, okay, well, is there training for muscle dystrophy that they can have? How do you guide this? We need help.
So I'm almost 99% sure that there is some training on the American Physical Therapy website for pediatric for the muscular dystrophy. And that's as far as you're going to get. We're not going to be able to get anything for RYR1. I think the closest we get is that. But I'll be honest with you, it'll probably very basic. So you could do what they did, is make sure you have a private therapist who can see him and come up with guidelines, and then talk to the school therapist if the school therapist is willing. But the first is you have to get services. I mean, if you don't have services, that's another battle that you have to climb. I mean, a hill you have to climb, a battle you have to wage, I guess, so all those, yeah.
Do you have tummy time tips besides just do it at an incline until they'll do it at less than an incline?
No, that's on your belly, on mom and dad's belly. Yeah, those are the. Yeah, just the basics. Yeah. I mean, there's a lot of devices out there, but then your home can turn into a piece of, equipment warehouse, and I'm not a big fan of those. There used to be sadly I don't have on there because I had this website on there and I checked it to make sure it was active, but it was called passitOnCenter.org, and it was a website run by the Georgia Institute, Georgia State, no, not Georgia, the college in Georgia, Atlanta. It's a university, I'm blanking on the name, but it was a university-run website, and they went to every state, and they would tell you which location had lending libraries for equipment. So what state do you live in? Ohio. So you could try Ohio Easter Seals to see if they have equipment, and you can try to borrow a lending library. Easter Seals used to have a lot of that stuff. Georgia Tech, I knew I would come back with. But that website is broken. It's a broken link, and it's not available. But you could try. But again, I think just basic tummy on your stomach,
We just can't get to the point that he'll try to use his arms
Yeah.
to do the incline instead of just using the pillow and then or flat.
Yeah.
His head, and it's just we just can't seem. We've been at the same hurdle for 6 months.
Is he not able to lift up, or is he not tolerating?
His head, if he's if he's propped on a pillow with his chest resting on the pillow, he can lift his head up.
Yeah.
But he won't do the bracing with his elbows.
Elbows, yeah.
It's hard for him,
Ah.
so he won't really try. I think he probably could if he would try.
Other than, the other thing is that I have, parents put their leg in, they are over the leg and all those, yeah. Yeah, I'm trying to think. That other device that I'm blanking on the name could come low enough that you could support the belly, and then try to work on hands and knees. I will find the name of the device before, yeah, so. Yes?
I'm
So that's what, so that's what we're trialing at our natural history study. So these are the assessments that are going to be done on the natural history study. We're doing, we're not doing manual muscle, you're doing manual muscle testing, right, Irene? You guys are doing manual muscle testing, but we're doing the quantitative muscle strength testing, which is this bed right here. And it's for kids 7 and older. And then we're doing these the functional measures, which is the motor function measure, performance of upper limb, Florida stand, 6 minute. And then the wearable sensors, so my interest, this is my personal interest, is that what you do in the clinic is different than what you do at home. So what we are doing is we're going to be putting sensors on the kids, both wrist, and they have a pendant. And then in the clinic, they're going to be putting on 6 sensors so we can check their walking and how they compare to walking, with the goal of when they go home with the sensors, they're going to go home with 2 wrist sensors and a pendant to see what they do when they're at home. So just think of like a very fancy Apple Watch or Fitbit or whatever, and it's research grade. The idea is that the one around the neck it works like a Fitbit or a Apple Watch. The one around the wrists are for the future for people who are not walking, for upper extremity limb, because there's nothing right now for upper limb function, so that's the future. So that's what we're hoping that we will move towards, because, so with the limit that if in the Duchenne trial, everybody's enrolling kids who are ambulatory. But what about the kids who are not ambulatory? And that's what we're trying to see if we can pull in some upper extremity function. And then for those who have walked and then lose the ability to walk, then do we lose that data? No, we want to be able to continue on. That's why we're doing an upper extremity scale and the upper extremity sensors. And these are very new. There's not a lot of research, so they're learning, we're learning, everybody's learning. So hopefully in 3 years, we'll have some information, so, yeah. So that's the future.
Do you know if there's off topic, is there a continuous temperature wear sensor on the market?
I met somebody here during this that has one through a phone. Through a watch. I can't remember who it was. Yeah.
The Apple Watch?
Yeah. Yeah. So I think that gentleman had a Garmin or something. I can't remember who had it. Yeah. Yeah.
She said it was a separate thing called Cord. She said it was expensive.
But it's on your watch?
No, it's a separate device that you can attach.
Yeah. For people who are ambulatory, then there's the commercially available Apple, Fitbit, Garmin. Just a quick note on Fitbit. I remember many, many years ago when they came out on the market, I actually contacted them saying, hey, I'm at NIH. You want to help work with me? And they're like, no, we want to do this retail. Like, we couldn't care less. We're doing it for healthy people. We're going to make a lot of money. So they didn't even. So those are the commercially available ones for people who are ambulatory. But for people who are in a wheelchair, to be able to track your movement, they have bike cadence trackers, so people have used that. So it measures how far you go in a bike. Yeah.
Actually, my son has an Apple Watch, and
And
it's like a wheelchair tracker.
Oh, okay, well, there you go.
Yeah.
That's good to know. I did not know that. So, is that a separate thing that you have to, or is it part of it?
Part of it, it knows that it knows.
Oh, okay, all righty. Well, now I have to change that slide. All right. Any other questions? This is what the one that we're using in our study. That's that. They need to make it look a little nicer, though. It kind of does look like something. Okay. Anyway, so here I wanted to thank the PT department and then Dr. Lawal's department. But if you have any other questions, my email was way in the beginning. I'm very accessible by email. It's right there, mjane@nih.gov. And you're welcome to email me anytime. Yeah. What? Yeah. All right. Any other questions? Yes.
So my son, he fatigues easily, and they recently recommended, what was that walking thing Rob with wheels?
Yeah. A gate trader?
Yeah, I think.
Yeah.
But because of the fatigue, the upper strength that
Yeah.
he needs, you know, they thought that it might not be working for him because he doesn't have the strength. Is there something like that that they can be more independent than sitting, or is there any new technology coming out like that gait trainer walker with the big wheels?
You were going to say?
My son, you're talking about the arm strength, my son's gait trainer has forearm rests, so he leans on his forearms and holds on and ambulates with his legs, so he's not doing that.
This, yeah.
That, it's like this.
But,
And no, it's not motorized, it's just a walker, and then it had a fold-down seat that he can either kind of sit on and rest, or sometimes he kind of uses legs when he was tired. Sorry.
so they do have wheelchairs have, it's not a motorized wheelchair, but they have again, I'm blanking with, oh yeah, it's a power assist. So you push it a little bit and it goes further. And some are activated by Apple Watch, like an Apple Watch kind of thing, they're controlled. And then the battery pack is supposedly easy to take on and off. So I don't know if they have that available on, for standing mobile gate traders, yeah. So those take up a lot of space though, yeah. So one thing I did not bring it up because it's very, very new in the market, and I'm sure somebody will come up with a question of it, but they have those external devices that are motorized, you know, think of Iron Man kind of thing, exoskeletons. So we just saw an exoskeleton-like thing at NIH. They came in to show it to us. It was very, very cool, but it was for very limited populations. It's not something that is scaled down to kids. One of the engineers in our department is working with kids who have cerebral palsy and trying to work on that. And it is cool. It's gonna come, I don't know, maybe, 5, 10 years. There's another study that I'm involved with where we're bringing it in for adults with limb-girdle muscular dystrophy. I think we brought 4 people in with it, and it helped them stay standing and walk a little bit. But it's still not ready for prime time. But I know Honda has a brand. Honda has one, but it's for adults, not for kids. So, yeah, exoskeleton, yeah. It's very cool. It's Iron Man-like, but it's not ready for prime time yet. So, all right. Any other questions? All right. Thank you all for staying. You know, I have to say, I did this session 3 years ago, and this is double the people that came last time. So, thank you for staying.